Hello, everybody. Welcome, dear friends of endoscopy. We have another endo talk from Endoscopy on Air. And in recent talks, we have been discussing the options of endoscopic resection, especially in the colon, EMR, and the next step, ESD. And there's always the question, is ESD the final step? No, it's not. So I'm very happy to welcome Leon Mons from Utrecht University, because he has been thinking about this for a long time. Welcome, Leon.
Thank you, Professor Rush. Thank you for the invitation. Happy to be here.
And so the question is, you know, surgeons are dealing with rectal lesions and local excisions. Why can't we endoscopists not go further?
I indeed believe that the gastroenterologist can have an important part in the treatment of rectal cancer, especially in rectal preservation. I think that it's important to say where we come from as a gastroenterologist. Normally we are trained to say that we have to look at a lesion, say that it is deeply invasive or not. And in the majority of cases, we do that based on optical features and advanced imaging. And if we say that a lesion is deeply invasive, we normally say, okay, we send them to the surgery, and the surgeon decided to go for a local excision or not. However, I think that with new knowledge, we know that deeply invasive colorectal cancers, and especially rectal cancers, can still be good candidates for rectal preservation. And I think that in these cases, it is really good to identify cases which we can remove. However, I think we do need to do some new things. Otherwise, we will not have the R0 resection we need. This is the selection of cases, of course, on optical features, but also on MRI. Because if you go into the field of treating deeply invasive rectal cancers, you cannot just rely on your optical diagnosis. You also have to use your MRI together with them. And the basis for selecting those cases, which are normally sent for total mesorectal excision, to go for a local excision, is based on recent findings or recent change in perception. At first, I think you have to know that for cases that if you treat them with rectal surgery, there's still a risk of local recurrence, which is about 4% in the rectum. And taken together with the mortality of 1%, you have a 5% threshold of which surgery is at least as successful as a wait-and-see strategy. If you look at recent insights on the depth of invasion and its as a strength of its risk predictor, of course, we know that deep invasion is related to lymph node metastasis. However, if you look at when only deep invasion is present, so all the other factors are absent, the risk of lymph node metastasis is quite low. So it's somewhere between 1.6 and 3%, which is below, to my belief, below the threshold of 5%. So deep submucosal invasive cancers can still be treated with a local excision. And if there's any other risk factor present, like tumor body, lymphovascular invasion, and poor differentiation, you might go for a rectal preserving strategy.
So Leon, in fact, we have to admit that we may have sent too many patients to surgery, or maybe to the wrong form of surgery. So the next step after ESD, which always had a narrow range of being curative, is so we have to get acquainted with a new acronym, which is called, I learned from you, EID, Endoscopic Intermuscular Dissection. So please show us how you do it. We are very excited to learn.
Yeah. Well, the intermuscular dissection is just using another space to dissect. We're all familiar with, of course, the submucosa to dissect, which we use in ESD, but there is also a space between the circular part and the longitudinal part of the muscularis propria. And we can go into that space. So in that way, we can remove the circular muscle, and then we have the resection margin needed for deeply invasive rectal cancers, and perhaps even for early invasive T2 cancers. And on the right, you can see an image of how that looks in real life, you can see the longitudinal fibers which are running away from you, and you have this circular muscle which is a little bit above, and then the submucosa. And to show you in a movie how you do that, this is a movie of a rectal cancer which showed P1 SM2 cancer with lymphovascular invasion. And we removed this lesion in the rectum, as you can see, just a few centimeters above the dentate line. And you formally do a normal ESD upon the outer margin of the lesion. You do not go underneath the lesion, you go up to the lesion, and then we go into the intermuscular space. And as you can see, we lift it a little bit, and then we just cut the circular muscle and to get access to the intermuscular space. And although you can't lift the intermuscular space as well as the submucosa, so you have less space to dissect, but you can still see that it is a little bit of a fibrous area of small filaments, which you can dissect easily with your ESD knife. The also thing is that there's not a lot of blood vessels, because the majority of blood vessels transfers completely through the muscle and start branching off into the submucosa. So you have just a few large blood vessels which you have to treat, but not as many as you do in ESD. And we use some kind of a tunneling technique, so we're going to start from the anal side, then from the proximal side, and just at the latter part of the edges. And as you can see here, it gives this kind of specimens where you have the tissue with underneath the muscle of the circular part of the muscularis propria, which you can stain with desmin, and it shows you that you have a well resection margin. And this, for example, this shows you the importance if you have for example, an SM3. This is an SM3 where it just grows into it, almost pressures against the muscularis propria. It's almost difficult or impossible to get in between with ESD, but with an AED you get this out quite easily. And I think that just especially for the deeply invasive rectal cancers still remain to the submucosa, AED is going to be a better technique to get an R0 resection.
So what you nicely showed is how you go through the different layers, right? So first you start with an ESD, go into the submucosa, but then very quickly you cut the first muscular layer. So how much space do you have in between? You said there's always some fibrous tissue. Can you blow it up with injection as usual, or where are the difficulties?
Well, the difficulties are that, of course, it also depends a little bit where you are in the rectum. In the distal part and in the mid-rectum, there's always a lot of space between the intermuscular area. But if you go into the proximal part of the rectum, it gets more difficult because the space in between is much smaller. I think that there is some space, but it is still not that wide as people know. So I think it's twice the thickness of the needle.
And how easy is it to preserve the underlying remaining muscularis? Is it sometimes gaping, and is there full perforation, or how often is it really well preserved?
I think in the majority of cases it's quite well preserved, because we dissect very close to the circular part of the muscularis propria. Because normally during ESD you want to preserve the muscle layer, and now we just want to preserve the longitudinal layer.
And you mentioned briefly vessels. So is bleeding more a problem or less of a problem compared to ESD?
You have a few large transversing blood vessels, which you can treat with your common coarse grasper or other hemostatic grasper. And all the other vessels are quite small. because the big vessels just transverse and go into the submucosal, and there they branch into all kind of different vessels which you can encounter during ESD. So you have less of a bleeding. Yeah.
Okay. What's also interesting, or what interests me and our viewers, is I think when you are not sure, you start with an ESD, but then you have to make a decision to go to EID quickly, because if you go with ESD too long, you get into the tumor, or what's the problem? Can you say I try an ESD first, and if I fail, I go to EID stepwise?
Yeah.
Or how do you select your cases?
Yeah, in the beginning of we did, for example, these are 3 cases which we encountered, and then it's quite clear. It's deeply invasive, and I think that we have to keep in mind that we are treating a real different part of the spectrum which we formerly used to treat with ESD. But if you want to start with ESD and you go upon your non-lifting, then you're too close to the invasive front. So I think the best thing is to discuss at the beginning of your procedure to go for AED or to go for ESD. And I think that if you're really in doubt and you believe that there might be deep invasion, I think it's better to go for AED directly, because if ESD goes upon non-lifting, I think if in 1 of 2 cases you will be too close to the invasive front, and the pathologists will say that there is a positive resection margin.
Okay, I think that's a very important message to everybody who wants maybe to start that after appropriate experience. So don't try ESD too long, make the decision early on to go 1 step further to EID. And so how do you select your patients, Leon?
What we do, but maybe we are a little bit different in the Netherlands, we use the optical model, which we published in the gut. And we used all kind of features, which are morphological features and advanced imaging. And we know from this model that if you have a risk above 40%, that is also very indicative for deep invasion. So at this point, if we suspect that there is deep invasion based on these optical features, and on the right I put the classical features, which we all know, like the JNet 3 or Hiroshima C3 or the NICE 3, or the Kudo pit pattern of deep invasion. When we have that feature, okay, we say, okay, this is going to be a deeply invasive rectal cancer, we do an EED, but not without performing an MRI, because we are very, very, it's almost impossible to discriminate deeply invasive T1 cancers from T2 or even T3 cancers. So the MRI is needed to say what is your upper limit of the lesion. And at this moment, we use the guideline of Gina Brown, which she also used in the PRESERVE trial, that if based on MRI, the muscularis propria is preserved of more than 1 millimeter, or there are no signs of deep invasion into the muscularis propria or beyond, T3, then we do an AED. So the upper limit is determined by the MRI. And we also look, of course, at the lymph nodes, whether they are positive or not. But we have to keep in mind that if they are positive in deeply invasive cancer, they are really positive. But if you use the positive lymph nodes in case of no signs, then the positive predictive value of these lymph nodes is less obvious. So we select cases on these features, this optical diagnosis together with MRI.
I understand from your presentation, you do not only use endoscopy, but also MRI. Yeah. And this is kind of an approximation, and probably you select some risk. So if the risk is 40%, as you said, or higher, you choose the more aggressive technique. But from endoscopy alone, is it possible? Do you have some examples for us?
Well, I think it's quite difficult to make a real clear distinction between deep submucosal invasion and T2 cancer. I think it's almost impossible. I think that everybody, when you look at these 3 cases, will see that they are likely to be deeply invasive. Perhaps not the case on the right, but the case on the right was was T2.
Oh, you should have asked me. Actually, I would have guessed, what we learned is the ulcer and infiltration. It's a sign of deep infiltration. You have the ulcer and then there is deep infiltration. But the right side lesion is rather flat and bulky. But this was that one with the deepest infiltration?
Yeah.
Okay.
Both the first and the second image are SM3, and the third one is in T2.
Oh, okay.
Superficial, of course, but T2. And I think that that when you go for these lesions, you do need to have MRI. So I think when you look at it and you say, okay, this is possibly a deep invasive T1 colorectal cancer, or perhaps T2, then you use MRI. And then both together, and also look at the age of the patient and the effect of TMA surgery or not, you can decide to go for a local excision.
Oh, I see. So I understand it's all very early, but from your daily practice, you get a lot of referral cases, I think. So how many do you exclude finally on the basis of endoscopy and even more so MRI? Is it 10% or 20 or?
I must admit that I think at this point we exclude 10 to 15%.
Okay.
But I think that everybody is looking at the lesions from an earlier perspective. So if lesions are more advanced, they are more thought to be T3 or whatever. So they're not being referred. But I think that there will be a growing awareness, and the border is going to change. And I think that with the border changing, it might be that we are going to treat more T2 cancers than we do now.
Okay, so I think that's a good keyword. Perhaps at the end you tell us a little bit about the preliminary clinical results, and also the question, couldn't you go further?
Yeah, let's go to that point. These are the clinical success this far. We've treated, this is the outcome of the 67 patients. And as you can see that the overall technical success is quite high. And if you look at specifically at the outcomes of the PT1 cancers with deep submucosal invasion, that's defined as SM2 or SM3, the technical success is about 98%, but also the R0 rate is 90%. And if you compare that, for example, to the R0 rates of ESD for SM2 cancers, which are reported to be between 63 and 70%. So this is much higher. And yeah, and the curative is a little bit difficult, I think, because now we defined curative as lesions with deep submucosal invasion, but without other high-risk features. But I think that even people with deep invasion and just one factor can be treated curative, or can have an organ-preserving strategy with radiotherapy, for example.
I agree. I think this might change. Both of us were part of a UEGW session where 2 surgeons were involved, and the surgeons are increasingly hesitant to operate on these cases and add other methods. So this gap, I think, in the future may be filled. But yeah, back to my question, could you go deeper? Could you do a full thickness resection with your knife?
Yeah, I will show an image like this, because this is where we started to do EED. But we encountered during the procedure that there was more deep invasion. And then we decided to go any deeper. And I think this is going to be the next step which we are going to use. Maybe we're not going to use the intermuscular space always, but at some point we just go directly into the space just underneath the longitudinal space. I'm still thinking about how to name it, because I think it's the perimysium where we go into, and not really because we do not go into the fat, we just stay just above it. But you can remove them, even T2 cancers or superficial T2 cancers, quite easily, and leave a small area of mesorectum open. And I think that in areas of the rectum where you have a lot of mesorectum, for example, the dorsal part or higher up in the rectum, that isn't the problem. You can go full thickness, and it's not really full thickness, but you can go into the perimysium, dissect it, and then close it, and or don't. We don't know. There's some conflicting data on whether you should close it or not.
Yeah,
but
that would have been
deeper. Yeah.
That would have been my next question. You know, you do these resections, they look beautifully, and what then? You leave the room, you leave the rectum, or you try to close it? There are more closure devices to come, or you place a sponge. So what are you currently doing?
Currently, if we have a full thickness excision, we close them, and in the majority of cases, we just use ultra clips, which is quite cheap and effective. And if we do an AED, we just leave them open. And we didn't see any problems with that. Maybe I can go into the complications. We only see some pain, but we've never seen abscesses or inflamed areas. We give them precautious antibiotics. One gift of, but that's only one time, and we don't see real abscesses. And there was a recent meta-analysis from thymus surgery cases showing that leaving the defect open of a full thickness excision does not have more complications than closing. So also among surgeons, there's a lot of discussion whether you should close a thymus defect or not. So I think that also accounts for us. If you go full thickness, why, and it is only small, maybe we shouldn't close it. But I don't know. I don't have the data yet.
Okay, that's great. You know, if the resection site looks as clean as you have shown on that picture, you probably can leave it because it seems to be intact. So Leon, thank you very much for this fascinating perspective. So in the shadow of the surgeons, we are getting through the wall. This leaves very interesting perspectives, maybe finally also for the upper GI tract in the framework of multimodal treatment. So again, thank you very much for this fascinating lecture. And we hope we can have you back soon with more clinical results. So thank you very much also to our viewers. So next week we'll be back with another topic of EndoTalks. Thank you very much.